So thanks everyone for coming. And then one final thing as we get started, thanks again, Katie, for coming to speak to us today about some of their data comments that they're working on. If the chat is open, but I suggest that you keep the chats questions until the end because those can be distracting to the presenter. So thanks everybody for coming to the COVID-19 data series. And take it away, Katie. Thank you.
Thank you so much. And thank you for having me. I'm happy to share what we have, what we're developing, and what's currently available for use on campus. For those of you who may not be familiar with Regenstrief, if you're driving down 10th Street, you've probably passed right by us. We have a building that sort of sits in front of Riley Peds and next to Eskenazi. We've been on campus for years and years and years, formerly in the health sciences building. And we have a shared mission to support research happening on campus. And we take that very seriously. Most everybody who works for the Institute is doing it out of pure love for moving health care and health systems forward. So thanks for having me and for letting me share what we've been working on. I'm going to cover with some amount of in depth, but I'm not going to take up the full hour because I would like to give you a chance to ask questions. I'm pretty knowledgeable in the data. And so if you have questions you're thinking about asking this type of data set, I'd be happy to tell you some of the ins and outs, and we'll get to that a little bit later. Again, my name is Katie Allen. I'm the program manager for the Data Core. The Data Core is a group of analysts that have access to the health data sources, and I'm going to touch on that in a couple of slides, and we'll go into more depth on the origins of the data. So let's get started. So early on in this pandemic, we realized that efficient access to COVID-related data was going to be very important. And we wanted to do it in a way that was both efficient for faculty and researchers, with speed, but also for our data analysts who were getting, as you can imagine, especially early on, sort of some of the same requests over and over again. If you follow the evolution, you know that we started with inpatient. Not sure what's happening. We started with inpatient. That was the sort of primary concern is how should we be treating these people? And then it sort of starts to evolve into longer term care and ongoing testing and things like that. So initially, as we were developing this, it was very inpatient focused to try and support those initiatives, but we're currently expanding. But again, the overall goal is to try and facilitate this access in a way that makes it easy for the faculty to receive it, and then try to also marry different data sources that are available, because the clinical picture is not the only item that we want to look at. So I'm going to take you a little bit through the process here on how we create a clinical registry. The first thing you have to do is identify your phenotype and your data elements. The phenotype was pretty straightforward. We're pretty lucky in that COVID is pretty easy to identify within the structured data or the clinical data, because you have a COVID positive test or you don't, or there might be a diagnosis code. And so phenotyping was fairly straightforward, but figuring out what elements to include originally was a little bit more in depth. And so we established an advisory team that consisted of infectious disease, pulmonology, critical care, to work through what types of data elements did they think they were going to be requesting or what might be important. And once we had those identified, we started creating these routine, ongoing data extraction processes to bring these data elements all together and create this registry. And so when you try to do this, you're thinking about not only this one-time extraction, but we knew we were going to be in this for a continued period of time, although probably most of us would admit we didn't think it would be quite this long. but you want to have these ongoing data refreshes. And so in addition to building these extractions, we built these processes. So the database actually gets updated once a week on Thursdays with all of these different variables coming in from the different sources. And then on top of that, we're actually just finishing up a process to create quality and data monitoring, a dashboard that sits on top of the registry so that we can make sure that everything's working the way that we want it to work. So let's get into a little bit of the details. I'm guessing not everybody has worked with us before, and so I am going to go into a little bit of depth on the data sources themselves. So the first thing with the registry is you have to pull together all of these different elements. And Regenstrief is lucky to serve as what we call the honest data broker for the Indiana Network for Patient Care, which is managed by the Indiana Health Information Exchange. So that was a couple of acronyms I just threw out. So essentially, the Health Information Exchange is a collection of health systems from across the state that are contributing data to one centralized source. And they've been doing this for a long time. Some of the initial connections go back to 1994. You see kind of a big uptake in about 2004, 2005 with a lot more systems joining. And all of the major ones you think about are represented in this Health Information Exchange. And the original purpose was clinical. They wanted to be able to share with each other to try and not say reproduce tests that didn't need to be reproduced. So if you showed up at an ED that wasn't where you were typically seen, the idea was they could pull up an application, look at your patient history, and maybe make some more informed decisions. And I highlight all that just to say that this is a clinically oriented health information exchange. So the data is being collected for clinical purposes, not for research purposes. But Regenstrief was put as this honest data broker, which is basically a neutral third party that says we will represent the health systems in that we will protect this data and run governance and only release it to investigators if certain criteria are met. And so we've been serving that role for 20 years now, 20 or 25 years now, being that liaison between the data source and researchers on campus. So we have access to that data set. And my characterization of IMPC is usually, well, sometimes I call it Swiss cheese, because it's all connected for clinical purposes. You don't necessarily always get the entire picture. And so it's really, really good. It's a good cheese, but it has some holes in it. And so you have to know those holes and be aware of them. And that's one of the things we also help the faculty and researchers do. The other thing I'll highlight with IMPC is that it's very broad. So you have data on lots of patients, millions of patients, but it's not necessarily super deep. Because the health systems choose what they send, they don't always choose, send the most granular level of data. Because again, remember, it was for clinical purposes. And if somebody's in an ED and they log in, they don't necessarily need to see, say, for example, the ventilation readings off of your hospitalization. That would be too much detail for them. And so the hospital systems don't choose to send that level of data, which is why we also have access to IU Health and Eskenazi's data warehouses directly. And so we log into a back-end version of IU Health uses one EMR, electronic medical record system, and Eskenazi uses another. So we log in two separate sources. But in those two sources, we can get to very granular levels of detail on these patients. And that has become a particular important feature for COVID as we looked at the inpatient data, right? So we are gathering ventilation data for these ICU patients and things like that. And so the way that the registry works, because they are three separate systems, that's three separate queries, three separate data models. We built processes for all three, and essentially every Thursday it all gets married together. Additionally, we get data from the state COVID testing. So all of the data, it actually comes in on a daily basis. We pull it in once a week to Cortico. And we're also getting the vital statistics data. So we're getting death, and we can get down to cause of death as well. So we're getting that for January 1st, 2020 moving forward. And then I think they're working on backloading previous data, although that's not super relevant to Cortico. The other thing we have is social determinants data. So if you're interested in area level measures, so say marrying your particular cohort to what their census variables might be, like insurance statuses for the census tract, we have all of that data already housed in another database, and then we can connect it up based on the census block is the smallest will go on area level measures. So that's kind of a overview of the different data sources that are coming together to form this one registry. And this is a non-inclusive list of everything that's in there, but just to give you an idea of kind of some of the big ones, right? We get the basic demographics. We have age and gender. Race and ethnicity is an interesting one because we have the health information exchange. We actually have some standardized queries that we run to say, okay, if this race was reported, was it reported elsewhere, so that we can merge and make sure we're getting the most accurate selection for each patient. And that becomes really important with ethnicity because some hospital systems capture it really well and some hospital systems don't. And so we can actually bring the health systems together to choose the race and ethnicity variables that are appropriate. I already mentioned the census tract, date of death. We can get to insurance status. That's another one. One of the big things the registry does is it takes a 2-year look back on every patient. And it says just what are the different comorbidities that they have in that 2-year time period. And then we're actually already calculating the Charlson, but you could easily do any of those other disease severity scores to give patients or to give people an idea of how sick people were. And that was the idea behind that. We have encounters. So an encounter is any interaction with the health system formally. So it's ED, outpatient, inpatient, although something with the IMPC data in general is that outpatient data isn't quite as good as the inpatient and ED data. And that just has to do with the types of facilities that are connected to the health information exchange. A lot of those smaller outpatient clinics just aren't connected. We have all the labs. We have selected a subset of labs. IMPC gets really great lab data. And so if you had a more rare lab that you wanted to include, we could always connect up and do that. But we did select it to a group of labs that our advisory team said would be most applicable to this cohort. We have drug fills. So that's not just if a physician ordered the drug. We have it if it was actually filled within some certain parameters. And so it depends on your cohort specifically, but essentially if the medication is filled at a participating pharmacy, which was quite a few in most of the major chains, a company called SureScripts manages that. And every once in a while from within IMPC, they send out a call to SureScripts and just says, basically give me the last 13 months of outpatient drug fill information for this particular patient. And so we capture that. And so we have some of that for some of the cohort, but not necessarily all of it. And so that's one of those things you'd want to kind of get into the nitty gritty with us about, just because of some intricacies around the SureScripts contract. And then I already mentioned the inpatient variables. We get a ton of granularity from the 2 warehouses. So we have ventilation use. We can tell very clearly ICU stays. We see them admit to the ICU. We see them discharge from the ICU, and we're collecting all of those dates along the way as well. And we can see inpatient medication, typically what's ordered. We can actually see like what's ordered, what's administered, down to very detail if you need it. I think we chose some higher level and just said, if they ordered it in the morning, it was likely administered, and we're going to just take those. There's some decisions you have to make along the way to keep it from becoming too big and cumbersome. We also have the vitals, so not just the ventilation use, which includes the type of ventilation, but also the level of oxygen, but then we also get vitals, so those oxygen readings coming off the individual, blood pressures, things like that. So where are we right now? So it's up and running. It's available for mediated queries. And what I mean when I say that is you can talk to the data core and tell us what you're interested in, and we can basically produce a data set for you. So if you say you're running a study and you want all 400,000 patients that are in there and all the variables, we can do that. In fact, we did one last week that was that big. Or if you just want a subset, you have a very specific question you have in mind, then we can really customize it for you, particularly if you're not used to working with super large data sets. You may not want a copy of the whole thing. You may want it tailored to your actual question and what you're kind of driving at there. The efficiency, though, is very much in place even through the mediated queries, because it's a lot less work for the data analyst to do to just tap this particular data sort. They don't need to recreate, going to those 3 separate places and trying to merge it and get it cleaned up. We've already done all that. And so the speed at which we're able to deliver these is much faster. The big thing we're working on, in fact, I think directly after this presentation, I have a call with this team. We're leveraging a company called MD Clone, which has a product. It is a front facing. And so what I mean by that is it's a tool that you would be able to log into that's going to sit on top of our data, and it would let you design your own query. And depending on what you have in place for governance, let you either play around so that you can answer feasibility type questions, like if you just want to know how many patients meet these particular criteria, or download what's called a synthetic data set. You don't need any big governance for that. A synthetic data set, if you're not familiar, is one that has been statistically reproduced. So basically they create a second data set that's completely fake. It shares the same statistical properties as the original one, but it's not real. And so therefore all of those HIPAA and privacy concerns go away. There are intricacies to doing that, though, because not everything can be synthesized. In fact, typically you'd want to have sort of a narrow data set in mind for that, because the more variables you add, the harder it is for it to synthesize everything. But that's really easy way to get access to some data quickly if you need it right away. But also if you're just wanting to play and explore a little bit, it'll be a good method for that. But then also the tool allows us to grant you additional accesses. So if you come to me with all of your IRB in place and we sign an agreement, a data agreement, we can actually give you the access to just download it directly. And so maybe you want a de-identified data set, it will strip everything out that it needs to, and it will produce a data set that you can just download. And so we're really excited about this. The technical processes are wrapping up right now, and then we'll get our validators are getting access. So we've had a couple of clinicians who have some use cases in mind. We're going to have them explore a little bit. And actually, if you're interested, please ask, because I'm always looking for somebody to poke at the system. And then once that's through, say probably early to mid-March, we'll start to roll it out for wider and wider use. So this is actually just as of Monday morning. We had 436 unique COVID positive patients in the data set. 6,400 of them have that granular data. So those are hospitalizations that we are reasonably certain were COVID related hospitalizations. And we've already fulfilled 25 different data or feasibility requests from this source. So it's gaining some popularity. And the other reason I like to highlight that is because it means that there are a few people have poked at it a little bit and have found any sort of little bugs or errors that we can get addressed to. And because I wasn't sure about your backgrounds, I did want to throw in a few little caveats. If you're not familiar with working with this type of data, there are some things to keep in mind. The first thing is that not all patients have the same amount of data. You may have made that connection when I was talking about how IMPC is very broad, but not very deep. So depending on where they're being seen, what and how healthy they are, we may or may not have a ton of data on them. And so a few of those COVID positive patients, we may have just that COVID encounter. Since we sit in an academic environment, you can imagine there are some people who don't really seek their care here typically, but we're COVID positive. And so we have just that encounter. We have that compared to patients that have been in the system since 1994. So it's really interesting, and it's just something to keep in mind that you do have to design your analysis plan to account for missingness and figuring out how you want to deal with this very real world data. And then the other thing I'll mention is that we typically do charge a small fee depending on what you need and the complexity. So, for example, if it's pretty straightforward and you just need a few variables from Cortico, that's probably going to be, not terribly expensive. And I mean, just, a few $100s. If you have this big idea and you need us to go back to the IMPC and bring in some more items and do that, you can imagine it gets sort of bigger and grows from there. And so with both of these caveats, my best advice to everybody who's interested in working with this type of data is just to come chat with us. Myself and the data analysts are always happy to have a quick call or a meeting and talk about what your question is, because we'd much rather walk you through what's going to work and what's not, and what are some recommendations we have right up front, and so that you understand both the data set you're getting and how you can address complexity depending on what you have available for funding and things like that. And if you're a student, sometimes we can find some assistance for the students because Regenstrief doesn't want that to get in your way. And so we just need to work through how we can address those types of things. So that is the end of the formal presentation. And I was saying earlier, as some of you were joining, I like that this was a smaller group because I think I would be really interested to hear like maybe what types of questions you have about the data, the research questions you're thinking of asking, and we can maybe get into a little bit more of the details. So. All right. Does anybody have questions?
I have a question. What is the Charlson comorbidity? Could you tell, like, what type of variable is that?
Yeah, so the Charlson Comorbidity Index is a validated calculation. So I can actually send a paper out where it assigns points to different conditions so that you can decide basically how sick somebody is going into your study. So for example, I don't know the numbers off the top of my head, but say diabetes would be assigned a 2, and cancer, history of cancer would be assigned a 4. And then it basically looks at all of these codes you've encountered. So diagnosis codes are what we use for tracking the different conditions. And it calculates a total score. So the higher the score, the sicker the patient, basically. And there's several.
Yeah, it's helpful.
There's several types of measures out there like that. I can never get the other one right. It's called like the Felix Eisenhower or Elix, I don't, something along those lines. That's another one. And I'm happy to answer just regular Regenstrief data questions too, if anybody wants to know more about how that works. Did anybody have a sort of a COVID question or something in mind or a project idea that brought them here?
Hi, Katie. I'm Claire Temple. I'm the HIPAA privacy officer, and health data steward. So I get a lot of questions about COVID data and the availability of it. And I'm just wondering, have you had any requests for data that are not necessarily research related?
Yes. So we actually have we have a completely separate process that's running for everything that would be considered public health authority right now. And I typically am not necessarily on that side of things, but some of you might be familiar with the Regenstrief dashboard that is showing all of the different metrics that the state is tracking. So there's the state dashboard, and then there's the Regenstrief one that gives some indicators like whether things are increasing or decreasing. That's all being run under public health authority, and so is not necessarily related to this, although we have leveraged infrastructure where we can so that we aren't recreating the wheel. But that's actually a really good point, Claire. Like one of the things to mention is this data and all of the data that Regenstrief outside of this public health authority use case, it has to be research driven. You have to have a research question in order for us to release the data to you. And that's, if you're not sure, you can ask. But yeah, we aren't, it's actually part of our contractual obligations. We're not allowed to release it for other purposes. So this, in the how long have I been? 12 or 13 years I've worked for Regenstrief. I think last year was the first time we had that public health authority authorization.
Yeah, thank you. That helps.
It's probably also worth noting too, if you're somebody who has been following this stuff a little bit, the count on the statewide dashboards for COVID positive patients will not match the Cortico population, even though the Health Information Exchange is pretty close to statewide. It's not exactly statewide. And so there are some pockets where we don't have data or alternatively aren't allowed to use it. And so you'll see kind of some discrepancies between those two counts.
So I'm interested in also what other, in addition to the COVID data, other data that Regenstrief has access to, just because I'm less familiar with you guys.
Yeah, so I started to touch I gave kind of the high level overview of the 3 clinical data sources. And within that, you can get to about any clinical question you have in mind. Just depend, like there's just caveats on how that data is captured. So we have access to both what we call structured data, and that's that coded stuff. So if you picture somebody, your doctor at the office and they're pointing and clicking and selecting things within that electronic medical record, that's probably producing some structured data. And that's the things we get to in those traditional queries that, you know, you might think about one of us performing. But we also have access to clinical notes. So they send quite a few notes to the Health Information Exchange. Those are much harder to search. We have what we call natural language processing technology. So we can do a bit of searching the notes, but it's not as reliable. And I bring that up because some things just aren't well captured in the structured data. A clinical one that comes up is ejection fraction. So that's a heart-related test that's performed with some amount of frequency. Those radiology reports, that number is in there, but for whatever reason, it tends not to be coded anyway. Nobody's entering that number. And that's also, we've been working on a project. This is another one that I've been working on to try and pick out those social factors and social determinants from the notes, because homelessness, food insecurity, transportation issues, unemployment, those things are usually captured more in a physician's note or a social worker's note than they are in a structured manner. Although that said, there have been huge pushes in the electronic medical record world to change that. And so we are starting to see some coded data entry there. So, but basically, if you have a clinical question, I would at least come talk to us, because, you know, a clinically oriented question, because we have access to so much. It would be rare for us to not be able to answer it, at least to some extent.
Awesome, thank you.
I was sort of expecting a few people who might have some research questions in mind, and to be able to work through a couple of them. One of the things I neglected to put on the slide is email address, but you can always get to us through Ask RDS, which is Regenstrief Data Services at Regenstrief, or if you just go to ridata.org, it will automatically route you to our presence on the Regenstrief website. And we've got so much information there about the data sources, the forms for accessing, so you can put in a request. We actually, through the CTSI, do feasibility counts for free. So if you're asking a question, you're getting ready to submit a proposal, you're just not sure whether the data is going to work for what you have in mind, you can go to the website and submit a feasibility request, and we'll be happy to take a look and see whether we have that data available. And in some cases, whether we have the amount of data available that you might need. So you can think about that in two ways. There's rare conditions where we just might not have the patient count that you're going to need, but also you might want to know, not just do the patients meet these criteria, but I also want to know about patient portal use or something like that. And we can tell you what type of data elements we would have available for that. And that's all available free to researchers on campus and actually across the CTSI campuses across the state. So it's ridata.org, and I'll stick those two things in the chat too. All right. Well, Lana, I'm not sure, but if there aren't specific questions.
Yeah, no, for sure. But this is really helpful, I know. in terms of, I had no idea about this data on campus, so it was very helpful. Thanks everyone for coming. A recording of this webinar will be sent out to all the participants, as well as if Katie has any particular other stuff she wants to send out. With that, let me know. I'll send that out in the next couple of days. This is the last of the data series sequence, but we'll probably be doing another one or two in March about different data areas. And I appreciate all your guys' time, and especially Katie for showing us some of the data that they have available over at Regenstrief.
Yep. Thanks for